Good afternoon. Thanks for joining us today. My name is Cybele Bjorklund, and I lead policy and government strategy here at Virta. I'll be moderating our discussion today while we talk with two terrific subject matter experts about how plans can combat the insulin cost crisis through creative strategies to improve health for patients with diabetes. We'll leave time at the end to take questions from the audience, so please use the Q&A function to submit. I think we're also going to have a few polls along the way, and we'd love your participation to help inform these conversations going forward. Next slide. So diabetes drugs are a significant cost driver for health plans. A recent report from the Kaiser Family Foundation showed they accounted for more than 1/3 of the top drugs in Part D whose prices outpaced inflation. But price is only one part of the equation. Given the sheer number of patients with diabetes, utilization plays a key role as well. Next slide, please. To address these cost pressures and help patients maintain and ideally improve their health, both plans and clinicians must pursue innovative solutions outside of traditional diabetes management. And when I think about the opportunities that plans have to make progress here, I will say that I think about SCAN at the top of my list of forward-leaning, mission-driven plans. Although I will confess that I didn't know until recently, despite having worked with them for decades on the Hill and in subsequent forums, that SCAN stands for Senior Care Action Network, and that is started for and by seniors. So that was a great learning for me as we prepared for today's webinar. They're a highly rated MA plan, consistently earning 4 and 5 stars, and they have 270,000 members in 3 Western states. More than 1/4 of their membership has diabetes, and many others have prediabetes. Next slide, please. We have 2 experts with us today, Dr. Sharon Jhawar and Dr. Bob Ratner. Dr. Jhawar is the Chief Pharmacy Officer at SCAN. She served as a key voice influencing Medicare policy at SCAN for more than 18 years, ascending through the ranks of her organization to her current leadership role. Prior to joining SCAN in 2003, Sharon completed a geriatric pharmacy residency program at the VA Greater Los Angeles Healthcare System. She has a holistic view of pharmacy and is going to share how they're tackling insulin and drug affordability for their members. Also joining us is Dr. Bob Ratner, who's the Chief Medical Officer at Virta Health. Prior to coming here, he served for 5 years as the Chief Scientific and Medical Officer at the American Diabetes Association. And for most of his career, he was a leading diabetologist and researcher in the Washington, D.C. area, where among other activities, he was a co-PI for the NIH Diabetes Prevention Program and DPP outcome study. He's got well over 100 publications to his name and has taught countless clinicians and helped guide people on their own clinical journeys, as well as doing research through the years. So we're going to start with Sharon to really dig into what plans are doing to manage their drug spend. Sharon, I understand that you have more than $1 billion in drug expenditures for SCAN's Medicare members. And given that Medicare beneficiaries tend to be on more medications than younger patients and are more likely to have diabetes, what are some strategies that you're using to manage your prescription drug spend in general and specifically for patients with diabetes?
Yeah, thanks, Cybele and Bob. Pleasure to be with both of you. Like you mentioned, drug expenditure is high, and one of the most top priorities and responsibilities I have in my role is really ensuring that for our Medicare beneficiaries, that the medications are affordable, so that they can manage their health. And so I would say top on my list of what I focus on is tight contracting that has continual rigor. If we think about the pharmaceutical supply chain model, if you will, there's the manufacturer, the wholesaler, the PBM, the pharmacy. And as head of pharmacy, I really have to ensure that I squeeze at every point in the way so that I can make medications affordable for older adults. So I would say, one first and foremost strategy, if you will, is to be a badass negotiator, because you have to have continual rigor to ensure that you're managing the prescription benefit continually all throughout the year. For us in particular, the older adults that we serve, their annual income is $35,000 a year. So let that sink in a little, right? Because if I want someone to be able to take care of their health on our plan, I have to figure out solutions where the medications are low to zero so that they can manage their health with ease. So that would be number one. Number two, I would say from a clinical formulary perspective, making sure that you have an appropriate formulary, but in certain therapeutic classes, as you manage a formulary, you don't need to cover all medications. And so what we've done as a strategy is wherever clinically appropriate, go to exclusive coverage, especially on the brand name side, to get the lowest unit cost. And that, can save quite a bit as you're then ensuring that you have low copays for your beneficiaries. Third, in the diabetes space, for us being in Medicare, I would say that the senior savings model that was introduced by CMS a couple years ago has done a great job in keeping insulin prices, copays stable for Medicare beneficiaries, in addition to consistent pricing for them, right? Not being affected by the so-called donut hole, if you will. And I honestly think we actually implemented that benefit design before the senior savings, 1 year before the senior savings model even occurred. And we did see our members not have a dip in rationing their insulin as they had that consistency there. And so our vision is that, hey, that has been shown pretty effective. And why don't we grow the senior savings program to also encompass some other brand name therapeutic categories? When I think about overall health of Medicare beneficiaries, if we just even expanded out a few categories, right? Anticoagulants, the anti-diabetic branded medications, and inhalers, we will have done a pretty miraculous thing in keeping Medicare beneficiaries' copays stable and consistent for them to manage their health. And then I would say that, for brand prescription medications, we don't have a perfect solution for all of our members. So if they happen to be in the diabetic world and on multiple diabetic brand medications, on our plan, 90% of the medications our members take, we offer for a $0 copay. On the brand side, so when you think about like the GLPs, the DPP4s and whatnot, copays can range for our members, annual copays for these products anywhere from $200 to $400 for the whole year's supply in these categories. And like I said, there's no perfect solution. So one of the things that our team is ideating on is how do we connect our members as they might be approaching the donut hole to patient assistance programs. Typically, manufacturers in the Medicare space will provide assistance when in the donut hole, but you can't apply too early. You got to kind of apply at the right time. And how do we on our end do that more seamless and timely for our members? And then the last thing that comes to my head is around biosimilars. So they have been coming onto the market, and we hope as they continue to become more available that they will be a source of being able to make medications more affordable. Right now, we haven't fully seen that, but hopefully more to come there.
That's really interesting. And I do think it's so important that people think about what plans are doing to control spend, and they tend to think about the more classic formulary issues. What are you using preferred? How are you jawboning the manufacturers? Where are the rebates going, et cetera? But the use of benefit design within SCAN, I think, is really, really important, and that you have worked really hard with the average income of your beneficiaries in mind to try to reduce costs and the connection to the pharmacy programs. We had our last webinar a few weeks ago looked at the broader drug pricing landscape and, the very opaque system that it is and how hard that is for people to navigate. So I think, until and unless we get a little bit more straightforward on that side, we have to help the patients connect with those assistance programs. And there's often redeterminations during the year, right? Once they are eligible, they get one batch, then they have to go back through the process again. So finding that commitment from the plan is helpful. So aside from medication management and including benefit design. Tell us a bit more about how SCAN supports members with type 2 diabetes more broadly on sort of the medical side and around food and other issues.
Yeah, so on one of those introductory slides, we kind of shared in our membership, about 28% of our members have had diabetes. And we know that our members have comorbid conditions with that, along with that, right? High blood pressure, cholesterol, all of that. And so we do have a laser focus on managing our diabetic members. Our approach is always to understand with each of our members what matters to them. And in managing their health, and how can we wrap around them as well as the provider delivery system. We operate in a capitated delegated market where we're located. And so the efforts that we provide really are meant to kind of hug and wrap around our members and the providers that they're getting care with. So when we think about it at a population health approach, we start off kind of by having those continual educating nudges and empowering our members around managing their diabetes or their pre-diabetes. You know, the normal like newsletter, our websites. We do in our membership what works really well. Our members really do like to engage with us, and teletalks are a great way for us to communicate with our members, whether it's on their benefits, whether it's on their health, and they miraculously, they stay on for 30-minute sessions with us on the phone.
Tell me what you mean by teletalk. Is it a telehealth visit, or is it like a webinar for your members?
It is essentially kind of like a webinar like this. And we set it up so that they can either join virtually or just via their phone. And quite honestly, the most of our membership, we do these in English and in Spanish. They join via the phone and they listen to exactly what we're doing here, but over the phone. And it's a great way for us to give them real-time information. It worked really well during COVID around the vaccination and all of that, to give them the latest and greatest of what was happening in their county and where to go and how to get the vaccine, for example. But we do this on a variety of different topics as well as their benefits. And then, you know, email and portal. We also do offer living well and managing self-management workshops for our members. But one of the things we do focus on from a whole structure standpoint is that we're all rowing in the same direction. So organizationally, we're focused on quality measures in the diabetes arena, and our providers are aligned all the way down to the pharmacies, so that we are helping our members, especially anyone that's uncontrolled, with any gaps in care and helping to keep them on track, if you will. We also do have a diabetic plan, product plan, and all of the members in it's called our balance plan. All of our members in there, they basically have this integrated delivery model with us, our care navigators, as well as our medical groups, the care management team and the specialists and whatnot. And we do the normal kind of health risk assessment, the care plan, and continual kind of check-ins all throughout the year on, you know, understanding the complications of diabetes, understanding what are the options as they progress through the care continuum, and really managing whatever health goals that they have set for themselves. So that's a little bit in terms of the programs we have. Then we have like two niche programs. One is our partnership with Virta, and for our members who are really looking for life change. If you think about, you know, the Virta program, it really is getting to the root of the problem of changing how we eat to reverse diabetes. And so for folks that are ready for life change, we really encourage them to connect with a program like Virta. And secondarily, what we found in our experience as we were helping our members is our Latinx Spanish-speaking members on insulin. They needed particular additional help and support. And so we leverage community health workers to go in the home, in the physician's office with them to their appointments, to make sure that there's extra eyes and ears on how to manage their diabetes.
I think that's so important because we hear a lot from patients, and I know Bob will be able to speak to this too, who, especially those who are newly diagnosed or see a change in their need, that too often they haven't had the kind of education that they need to know how to help manage it. So we had a patient the other day speaking to us at Virta who was saying that he had been diagnosed and sort of sent on his way and told not to eat sugar. Well, he knew I shouldn't have desserts, I shouldn't have ice cream, things with sugar, but no one had bothered to explain to him that carbohydrates are sugar and that he should avoid carbohydrates. So he continued to eat carbs and other things, and sure enough, ended up at the point that he needed insulin and more serious management until he came to us, and then he managed to turn it around. But he was just saying, nobody told me what I needed to do. So I think that's really important what you're doing. So on that note, Bob, I think part of what's always interesting to think about is that there are many different treatment paths and trajectories for patients with type 2 diabetes. But for many, it means a chronic condition that would get worse over time if they're not carefully managing it or taking steps to reverse. Can you give us a sense of the range of treatment options, and if this is possible, what treatment looks like for a typical person with diabetes?
So the difficulty is, how do you define a typical person with diabetes? One of the issues that's been coming up over the last 3 to 4 years is that it looks as though type 2 diabetes is actually multiple different diseases. So that, for example, the 14-year-old American Indian who develops type 2 diabetes has a very different natural history and course of disease than the individual who develops diabetes at the age of 78. And that different phenotype really requires a very different approach. Let's focus on the, quote, traditional type 2 diabetic, the individual who develops diabetes at the age of 50. It's usually a lifestyle issue. They have a very strong family history. They're usually overweight. They're usually sedentary. What you see is that they're identified as having a touch of sugar, if you happen to be in the South, or a mild case of diabetes. And just watch your diet. And in most cases, physicians, clinicians don't have the time nor the expertise to really sit down with them and talk about what the pathophysiology is of diabetes and how to deal with it. So the example of the patient that you mentioned from last week is very, very typical. So when that happens, what you see is this progressive increase in weight, progressive increase in glucose, and a progressive increase in the need for medications. Now, within the senior population, we're seeing something very differently. Type 2 diabetes is a disease of aging. And as you get older, your risk of developing type 2 diabetes goes up. But the pathophysiology appears to be somewhat different. And we need to be very, very cautious about how we approach these individuals. So let me give you an example. In that 14-year-old or in that 50-year-old, we have to be exceptionally concerned about macrovascular complications. We know that in adolescent type 2 diabetes, we're starting to see strokes and myocardial infarctions in their 20s. So it occurs very, very quickly in adolescence. In the 50-year-old, it takes 15 to 20 years. We don't worry about that in the 78-year-old. Chronic complications are less of a concern in the elderly. What is a much greater concern is the risk of hypoglycemia. So some very good studies done by the group at Yale have looked at geriatric populations and over time looked at hospitalization rates and their causes. Hypoglycemia, low glucose, is now a more common cause of hospitalization in the geriatric population than is high glucose. That all goes to the complexity of the medical regimen, the confusion that many of our seniors have in terms of trying to figure out Which insulin do I take? How much insulin do I take now? Did I even take my insulin? People tend to forget all of those issues. So the risk of hypoglycemia has really risen significantly and become an overriding concern in the treatment of seniors with type 2 diabetes. So if you take that typical patient whose glucoses are going up, who has medications added to the regimen sequentially, because the clinician says, your hemoglobin A1C is too high. You're running 8.5. We need to get it down. There are two major senior community. Number one, are they actually taking their medicine? We know frequently that individuals stop taking their medicine. 50% of people stop taking their medicine after a year. So we need to know what the patient is actually taking. It's far too easy for a clinician to say, well, you've been on 40 units of insulin glargine per day, let's take you up to 50. Well, if they're not taking it, 50 isn't going to help any more than 40. On the other hand,
it could do a lot of damage, right?
Exactly right. If that one time they take that higher dose, it may be far more than they really need. And that's what results in the hospitalization for hypoglycemia. What we've done is we've taken a very different tact. We try and understand the pathophysiology of type 2 diabetes among our patients, and we try and utilize food as medicine. So that if we focus on this underlying environmental exposure, then what we can do is very rapidly deprescribe medications so that we know that if you cut your carbohydrate intake abruptly, your postprandial glucose levels fall significantly. Now let's think about this in the real world. If a patient is just reading about carbohydrate restriction and they say, well, I'm going to give it a try. And so they cut out their carb, but they haven't made any changes in their medications, particularly insulin or sulfonylureas, next day hypoglycemic. They'll never go on that diet again. In fact, they probably won't go on any diet again if they have an adverse effect. What we're doing is looking at the science, knowing that if we cut carbohydrates significantly in patients who come to us, that we need to proactively deprescribe sulfonylureas and cut way back on prandial insulin. And we do that before they initiate their nutrition therapy. By doing so, we're removing the most common causes of hypoglycemia in the geriatric population, insulin and sulfonylureas, and we're monitoring them in such a way that we're actually improving their glucose control. So what we've seen is that the natural history of type 2 diabetes does not need to be this inexorable climb in glucose and climb in medications. We can reverse it by utilizing food as medicine, getting people off of these medications that have significant detrimental side effects and improving their overall control. Now, let me add one caveat. There are individuals with type 2 diabetes who can never get off of insulin. And we need to recognize that. There is a form of diabetes called latent autoimmune diabetes of aging, which is actually a form first of type 1 diabetes. These individuals actually need insulin, so that we're monitoring that as we begin to decrease the dose of prandial insulin in particular, but we maintain that basal insulin unless we are absolutely certain that this individual is not going to develop diabetic ketoacidosis. What we see in our patient population is that about 80% of individuals who are on insulin when they come in are able to completely come off. In those 20% who remain on insulin, we do that for safety reasons. Their insulin requirements are diminished by about 80%. And they're typically on a very simple regimen of long-acting basal insulin.
Thanks, Bob. I think that was really important to sort of end on that high note, because some people listening might think, well, it's dangerous to reduce your carb intake. It's not dangerous if you're being clinically monitored. It's in fact really important for your health. The danger comes if you're doing it without staying in close contact with a physician who's overseeing your care and able to titrate the medications appropriately. Sharon, when we spoke in an earlier conversation, you mentioned that medicine should be a last resort, not a first, which I just love as a pharmacist, that you're looking for ways to reduce the need for people to have medicines, even as you dispense it for those who do need it. Can you talk about why it's important to pursue appropriate deprescription? Is there anything to add with what Bob was saying? It's also, we end up with a halo effect on blood pressure and in other areas too, that as people with diabetes see their health improve, we're seeing improvements in other areas. But I'd love to hear you talk about why pharmacy should be, in many cases, a last resort, not first, when there's an appropriate substitution.
Yeah, I think we use this term, right? Food is medicine. And if you just reflect for a few moments on like, hey, what does that mean, right? As Americans, if we all throughout our day think about when we're eating, are we intentionally putting in the right things in our mouth that serve our body well and prevent the need for popping a pill? I think we live such busy lives that probably gets lost a lot in our day, but really there is nourishment that we should be giving our body in order for it to work well. And sometimes, right, if we haven't done it well enough, then we develop things like type 2 diabetes. And then, we head down this path of, okay, let's figure out if a medication can help fix it. So I think the notion of food as medicine is an important one to just keep in mind in how we eat and treat our bodies. And what I like about, the program around Virta is that it is kind of fundamentally addressing type 2 diabetes from the root for those folks where it makes sense. That caveat is super important. And so it's not easy to change the way you've been living your life. And so I think that as you kind of progress in your health, always asking the question of, are my medications that I'm taking right now, are they the right ones? I kind of use this term, a medication tune-up. You get your car tuned up once a year, and it's not bad to take a look at the medications that you're taking and say, are they right for me now based off of where I am and what I'm doing? You kind of heard Bob talk about, in the Virta program, as you're going to shift your diet, you're already changing your medications up front to prevent hypoglycemia. Same thing with your medications. As you progress in what you're doing in your life of how you're caring for yourself, things may change with your medications as well. And so, for folks on medications, I'm a huge proponent of medication tune-ups.
I love that. It kind of reminds me, people used to talk about, encouraging particularly Medicare beneficiaries, but really anybody who's on multiple meds to brown bag it, right? To bring all their meds in to a physician or a pharmacist and say, do I need to be on all these things? So many people get something ladled on by someone else if they're not in a coordinated system, and then they're just not sure what they should be taking, and working at cross purposes, have contraindications, or just frankly over-medicated if they don't need it. So.
And what I would say, Cybele, is a lot of times when I've done the brown bag of go through all the medications, understand why someone's taking it, even just at my temple, the number one question is like, can I save on my medications, or do I need all of these, right? And as I go through and kind of help them manage their medications, if we're able to simplify their regimen or stop anything, the number one thing where I go, man, something went well here is when they call back afterwards and they go, you know what? I have more time in my day because I'm not worried about the next dose that I'm taking. to actually live life. And I think that's a really cool piece that when I hear that, I'm like, okay, not only was it not necessary for them to take, but then they're able to kind of focus on other things going on.
I think there's a certain level of stress if you're on a complicated regimen of, just as Bob even said, remembering to take it, or did you take it? And, I've watched my father struggle with this, what has to be taken with food, what is taken without food, and how you titrate that around your meals of the day and everything. I think it is complicated. And I think when we see our patients begin to reduce or eliminate meds, I think that contributes to, what we internally say is the delight of the program and why people stay on it, even though it's an intensive change, because I think it's very motivating when you're no longer sticking yourself or taking as many other medicines that you feel pretty motivated to stick with the changes that you've made and sort of your hard-won progress. We've got also, actually, it's been interesting for us working with SCAN. We've been really excited to see some of your patient success stories. And I don't know if there's any real life story you'd want to share with us on behalf of any of your members.
Yeah, so we are in our early stages with our members participating in the Virta program. Very preliminarily for our members that are in the program, seeing positive results. So far, kind of like at the 90-day mark, if you will, we're seeing in our members having a reduction in A1C of about 1.3%. On the weight loss side, we're seeing about a 5% weight loss reduction. And then in terms of scaling back on diabetes medications, we're at about 30%. So positive signs for kind of early into the program. And I'm sure that's going to grow over time. One of our members, Deborah, she's also a senior advocate at SCAN. We have a team of folks who are not only employees, but also members of SCAN. So they are over the age of 65. And she joined the program. She's been on the program for about 6 months and lost about 25 pounds, kind of had the A1C reduction of almost 1%, feeling super energized. And when I was hearing Deborah speak about kind of, how it's helped her in her life, there were a few things that I gleaned on, like, hey, what made it successful for her and the program? And she was sharing with us that as she was caring for her mother, and when her mother passed, it was really that life moment where she was thinking to herself, I need to take care of myself so I can be there for my kids and my grandchildren. And she wanted to take an active role in managing her diabetes. What we find a lot of times is that reason and that motivation really matters when you're coming into any sort of program or changing, wanting to make a life change. Number two, what I felt like led to her, having the 25-pound reduction was a health coach. Having someone by your side. So she had great family support, but on top of that, the health coach that's there right by your side, checking in on you, giving you tips and recommendations on tailoring your food changes. I think that's instrumental in order to have success. And then that deliberate focus that she then had on changing her diet and really having those tips that worked for her, right? If you talk about like reducing carbohydrates, it's a scary thing to think about, like, well, then what the heck am I going to eat, right? But then actually understanding, oh, I can eat cheese, I can eat eggs, I can eat, and that you're not starving. I think that goes a long way in people understanding and feeling motivated that they can do it. So that's kind of one of the examples that we've seen so far.
I think that's really interesting because I do think it highlights the person-centered nature of an approach like this, which creates both challenges and opportunities, right? There are different approaches that you might have for Latino members who, again, using your promotores or community health workers and others that might, and obviously in Spanish language, as opposed to someone who's still working. And, because in your Medicare population, obviously some people are still working, other people are retired, how they fit that into their daily life. As you said, what kind of support they have when they're in a grocery store trying to make a decision, buy this, buy that, or out to eat, or cooking at home, or confronting a holiday. What do we do on holidays with a dramatically different eating period? So I think having that kind of person-centered approach and support, it sounds like, is really important in the SCAN population and in any population. So I think that actually brings up this notion of digital health, where I also think digital health has both a lot of promise, but also some challenges in terms of how telehealth can help address disparities. I'd love to see evidence from either one of you on these issues, for or against. Where are the places where digital health can be closing gaps? Bob, you can talk about this in terms of what we've seen. Where are places where it might be a little bit where we're actually able to close gaps more readily because of the accessibility?
So one needs to be very careful when they talk about telehealth. What's happened during the pandemic is that we've kind of created this new doctor's office visit for 10 minutes on Zoom. It's considered telehealth, but it's no more beneficial and probably less beneficial than a face-to-face 10-minute visit twice a year. And that's what a lot of people have been doing. What we've done is we've defined a category called continuous remote care. It's all virtual. It's done through apps. It's done through texts. It's done through telephone calls. It can be done through Zoom, but it doesn't need to be. And what we're doing is we're collecting data from patients on a daily basis. We're interacting with patients almost on a daily basis. At the beginning of their therapy, it's absolutely every day. The longer they're in, the less support they need, and the interactions may decrease. But it's that level of high-touch medicine that goes with the high-tech medicine that makes continuous remote care much, much better than, quote, telehealth. So let me give you one example of success and one example where we're trying to see whether or not we can reach hard-to-reach patients. Virta got started before the pandemic. So we have data on patients for the 12 months prior to the pandemic. When we look at the impact that our intervention has, specifically on weight, what we see is that during the pandemic, the weight loss is identical to the weight loss that we saw prior to the pandemic. Now that becomes important in two regards. Number one, the CDC has said that the coronavirus pandemic is an obesogenic environment. What you saw was a 1 pound per month weight gain on average in the American population because they were locked down. We didn't see that. What we were able to do was completely wipe out that weight gain in individuals who joined us during the pandemic, so that you can begin to see that telehealth can work during a pandemic. It can work without a pandemic as well. Now, one of the concerns that people have, including me, is whether or not you can reach individuals who are not tech savvy, who may have problems with broadband and cell coverage, who may have health literacy issues. So we are currently working with the University of Colorado, looking at a cluster randomized trial of individuals who live in rural areas who are exclusively served by federally qualified health centers. So it's a low-income population, it's predominantly Hispanic, and most of these people are on either Medicare or on Medicaid. And they live 60 miles from the nearest provider. And so I can't give you any results yet because we've not finish the study, but we're very interested to see if we can specifically reach out to populations at risk.
I think it's really important to figure that out, because I know we've seen in our other private health plans that we're covering, the same physiological responses, obviously across race and ethnicity categories. But the question is how the whole complement works with a more medically vulnerable population that's have limited resources and not just in terms of income, but literacy and tech access and support from their on the ground regular PCP providers who are helping them out. Sharon, one of the things though, that speaking of, Bob mentioned broadband access. Can you tell us a little bit about SCAN's program? I think this is a really interesting, novel program of how to support your Medicare population, which is your whole population. One of the fun things about SCAN is you can really specialize and dig deep on what seniors need. How you're supporting them on the technology front, because so many treatments are moving to have some form of a digital access point these days. And I think you guys, again, proactively were doing this in front of the pandemic, but I'm sure it became enormously important during the pandemic. And I think it's an interesting model for other people to look at.
Yeah, Cybele. So, as we've been kind of keeping a pulse on our members and how they want us to communicate with them, we heard an overwhelming, and the AARP 2022 tech trend study kind of shows similar sentiments that older adults want to learn more on how to use technology, whether it's for entertainment, whether it's to manage their health and whatnot. And so, we offer some supplemental benefits like a Fitbit, like a personal emergency response. And what we found at the, years ago, as we began to offer those benefits was that in order to get set up, you have to have an email address. And our members would call in and say, I don't have an email address, right? And so here our member services, team was helping them set up their email account. And from that, we ended up launching HealthTech. And our members can call in and get help with anything digital that they need help with related to their health. So whether it is to get ready for that upcoming appointment with their doctor that might be virtual, like we kind of had happen during the pandemic. If it's, setting up their Fitbit or whatnot. We've also, as the pandemic kind of, as things kind of evolve with the pandemic, we're actually able to also go into members' homes. So if they need help with someone sitting there right next to them, helping them with their iPad, we're able to do that. So you can kind of think of it as like the Best Buy Geek Squad for helping seniors kind of manage this new and latest technology. And one of the things, as we have been trying to say, how do we keep getting better at helping folks in this area on this digital divide? I was actually calculating, hey, how many years is something like this going to be useful as we think about the aging population? And we're probably going to need this kind of bridge, if you will, and helping folks with technology for at least, when I was calculating it, I came up with about at least 9 years to get everyone, acclimated to technology as it continues to evolve. One of the things, so in our membership, as we were taking a look at, our members partaking in the Virta program, of where we're looking at next is how do we engage with them so that they know about the program in the way that matters to them? So for some of our members that are, let's say, happen to be on Facebook and that are texting, how do we let them know of the program in that manner? For other members of ours, where that's not even where they're at in their life, how do we kind of share the program in their space? So, are there a trusted circle of people, their physician or their pharmacist, or who is it, and how do we get them engaged that way? So those are some of the things we're taking a look at. And from an equity lens, I don't have the answer today, but as we've kind of started this program, we know that a disproportionate portion of our Latinx members have uncontrolled diabetes. And to say, hey, as we take a look at the folks on the Virta program, do we see that disproportionate Latinx members in our program? And if not, we're not doing something quite right yet, right? And getting to them and helping them and engaging with them.
I think that's so important, because I think the promise of a digital approach and having basically a computer in your pocket once you know how to use it is that you can get this care I talk about it as being low, it's less intrusive in their daily lives. As Bob was saying, you can have this push and pull where beneficiaries are asking for help and clinicians and coaches are reaching out to them, depending on what the situation is, with multiple touches during a day, as opposed to taking time off, going across town, sitting in a visit and coming back out. So the promise is you can get it to everyone, everywhere. The challenge is, where are the pockets on literacy, tech literacy, health literacy, et cetera, that you can still have it be meaningful. Well, I know we need to wrap up for questions, but would really love, Sharon, for you to give us a quick download on preventive pharmacy at SCAN and in general, and what that means. I found that to be such an intriguing concept.
Sure, yeah. So let me start off by saying, if that term is not coined yet, it is not my term. I love it as well, Cybele. A colleague of mine that I work with, Matthew Pasquale, as we were kind of figuring out a 5-year strategy in pharmacy for our organization, this concept really emerged, right? And it really resonated with us. And as we think about the pharmacy profession in general, I think, pharmacists are ripe to be a part of, the health and well-being and prevention of folks. And so, I think that as we evolve there, preventative pharmacy is really an angle of and a goal that we should strive for. So when I take a look at like our members, for example, 65% of our members are on a monthly basis utilizing the pharmacy benefit. For me, as I think about the role the entire healthcare delivery system, in addition to the pharmacists on my team and the role that we play, wouldn't it be great over time to see that percentage decrease in terms of the amount of medications we need to manage chronic conditions, because we're doing it from the root, whether it's food as medicine or prescription for exercise as opposed to a pill, for example. And what I would say is that, our sense is that as you manage your health, you need a lot of positive nudges, and a pharmacist is available quite often, right, in the local community, in a grocery store. And as a good person, over time, if they, one of the obstacles we see is can they get to the front of the counter as opposed to behind the counter, and start engaging more with folks as they're making those food choices. But preventative pharmacy, I think in my head, is an aspiration that we want to move towards in terms of Americans being more healthy. And as I think about it for SCAN, it would be, reducing the need for medications where appropriate.
Oh, but thank you. So Bob, we're going to try to do a couple of questions, and a few have come in for you. One is talking from Tom Hawkins at Blue Cross Blue Shield of Massachusetts, asking if Virta's deprescription parallels what happens after bariatric surgery, and that they're kind of looking at Virta as an alternative to surgery for some, for the patients who are wanting to do that.
I do believe it is comparable, and I would love to work with Blue Cross Blue Shield of Massachusetts to do a controlled clinical trial of bariatric surgery versus Virta. What we see, well, let me take a step back. Recently, an international consensus conference defined diabetes remission. Diabetes remission is what bariatric surgery has been striving for years. And if you look at their outcomes, they have anywhere, depending upon the center, between 16% and 40% of individuals with diabetes achieving remission. With bariatric surgery, what you see is that the earlier in the course of disease that you operate, the greater the likelihood of success. When you get out to 8 to 10 years of diabetes, the success rate falls precipitously. We've only been able to look at 2-year data so far, but our remission rate, the International Consensus Conference definition, hemoglobin A1C below the threshold for the diagnosis of diabetes on no meds for at least 3 months. We have a 25% remission rate. So we do think that what we're doing is comparable to bariatric surgery. Now, I will tell you that our 1-year weight loss is not as high as bariatric surgery. But in fact, how much of the weight is cosmetic as opposed to medical? We know from a lot of studies that if you lose 5% of your body weight, you have a significant metabolic benefit. And in fact, it's that 5% that's the threshold for approval of weight loss drugs by the FDA. We're achieving 10 to 13% weight loss at a year. Obviously, bariatric surgery is achieving a lot more. So if what you're looking for is cosmesis, yeah, there's not much that can compete with bariatric surgery, with just melting pounds away. But the question is, how sustainable is that? How expensive is that? What are the upfront costs? What are the upfront complications? So we would love to actually do a research study comparing us to bariatric surgery.
I'm looking at all the biomarkers, not just weight alone, where again, we exceed a clinically significant weight loss measure, but and we can get up into the pounds. It depends, I guess, where you've started. So I think, Sharon, there also seems to be a lot of interest from the questions on teletalks and outreach to senior members and how your SCAN members are communicating and using text or other virtual aspects. Can you give us just a quick insight into that?
Yeah, so I saw some questions come in about if members can ask questions during our teletalks, and we do them both ways. So depending on the focus of the teletalk, we set it up where questions can come in during the actual talk, and in some cases, depending on the topic, it might not be conducive to that kind of setting. Keep in mind, some of the times, right, with thousands of members, you want to kind of take the streamlined questions. We do have a way for them to actually submit their questions before the actual session too. And then also, how do you find out what matters to your patients? So as it relates to care management, as we're conversing with our members, that is a focal point of the conversation. In addition to that, we have many channels on listening and understanding what matters to our members. One is a SCAN Listens, where we routinely, on a variety of different topics or issues that we are internally thinking about, we actually reach out to our members directly and poll them. And we have a SCAN Listens community. There are members who have volunteered to partake in this process on a variety of different topics all throughout the year. And then, like I mentioned, we actually employ some of our members, our senior advocates. And anytime we have a great idea that seems great to us, we always use them and say, hey, what do you think about this? And so that's really how we know and find out from our patients what matters.
It's always good to get a reality check from the people you're intending.
Exactly. Exactly. You can have a great idea and then others go, no, that's just not going to work.
Well, and on that, when somebody else had asked about SCAN members or our other senior patients using texting, and we do see that. I mean, again, for the people who have, self-selected to use Virta as their intervention, there is a certain amount of health and tech literacy that they have to be brought along to and engage with. And so then they are using texting and engagement with the coaches through the app for us, and I assume for SCAN as well. So another question that came up, Bob, was, actually, this is kind of for both of you, Bob, putting on your clinician hat from years of practice, but those medication reviews, can those be done virtually or remote instead of having to go in face to face? Would they be able to get that kind of review and assistance with medication? Not just in our classic deprescription, Bob, but it sounds like they're asking about the brown bag type of thing, to be able to do those visits remotely.
We've been doing them remotely now for years. So the answer is absolutely you can. And in fact, what you can do is take the incoming data with glucose measures and ketone measures, which is the incoming data that we collect along with weight, and then return information to the patient in real time about what they can do with those medications, whether it's cutting doses of prandial insulin, or it's deprescribing sulfonylureas, or deprescribing DPP-4 inhibitors. And that can all be done virtually.
It's fantastic. So there's somebody else that asked in the chat, because really our focus is here on type 2, had asked whether there was an analog that can be done to help people with type 1. And obviously, Bob, as you've taught me and can speak to it better than I can, a type 1 person will always need insulin, although they may benefit from eating fewer carbs. Friends of mine who are type 1 tell me all the time, I feel better when I eat fewer carbs, but I have a pump, so I can have the plate of pasta, push the button.
Yeah, the difficulty is that insulin is life-saving in type 1 diabetes. So you suddenly have this difficulty in balancing the risk of hypoglycemia if you've given too much insulin with the risk of diabetic ketoacidosis and potential death if you haven't given enough. We've not studied type 1 diabetes for safety, and I would not recommend our well-formulated ketogenic diet for anyone with type 1 until those data are available.
Thank you. Just helping clear up for people who might not be as familiar with the distinctions there. We're coming to the end. I think we have time for probably one more question. And this is this notion, Bob, I think I'll turn to you on this as well, about reversal versus remission versus cure. And why, for example, we don't talk about curing type 2 diabetes.
So we've kind of adopted some of the language from the oncology world, where cure requires 5 years of no therapy in order to say you're cured of cancer. And we always are treating people with therapy, even if it's food as medicine. We don't take people off food as medicine. And so we talk about remission as being defined as glucose levels under the threshold for diabetes with no meds for at least 3 months. That's the international consensus. What they also said was that reversal is the process by which you normalize glucose. So our reversal process is this well-formulated ketogenic diet.
And I think it's important because people, will say, well, isn't that the same as a cure if you get to a sub diagnosis level of A1C and are not having the meds? And what I've colloquially told people, so you can fact check me here, is, well, but if you were to start eating a high level of carbohydrates again, you would raise your A1C. So, it is the continued maintenance over time of what got you to the state, unlike some cancers where you can entirely eliminate it from your body and stop, obviously, your treatment.
Exactly right.
So with that, for everybody, I want to thank Dr. Jhawar and Dr. Ratner for joining us today. I want to say there's a lot of questions we didn't get to, and I think our team will try to help answer some of those offline for those of you who had questions about Virta or other questions that we could answer directly, but we didn't get a chance to do in this chat. And thank you for tuning in. Be on the lookout for future webinars, and we hope you have a great weekend.